This is Marianne Pedraza at the University of Arizona Global Campus. Today I will be speaking to drug overdose in Contra Costa County. Contra Costa County, California has seen increasingly numbers of opioid fatalities, with approximately 14,000 deaths per 100,000 people in 2015 to approximately 30,000 deaths for 100,000 people in 2025, which is more than double. All age groups are affected, and males are at higher risk than females. A community-based intervention study that evaluated naltrexone, which is a treatment for the prevention of opioid overdose fatalities in high-risk ethnic communities, was performed in Massachusetts and Rhode Island. The research question was asking, do high-risk communities with a significant number of racial and ethnic groups have equitable access to naltrexone? The research hypothesis is asking if high-risk minority communities, especially Black Americans and Hispanic Americans, have inequitable access to naltrexone. The methods in the study, it was a retrospective study, so there was no active participants. This focused on communities in Massachusetts and Rhode Island with high drug overdose rates. Government data such as surveillance records and census looked at opioid fatality rates and population demographics. Naltrexone availability and distribution was gathered through community program data and pharmacy logs. Method suggestions for future studies in recruitment and enrollment would be to incorporate participants for comprehensive patient perspective. This would be community-based and would partner with community government leaders and faith-based leaders. Include community members in the research staff to ensure cultural inclusivity and any translation needs. The variable types within the study, the independent variable is the naltrexone kit distribution, measured through community program data and pharmacy logs. The dependent variable is the overdose fatality, measured through death records. For validity and reliability improvements, validity improvements would be to standardize overdose fatality across states so that it is consistent. Include qualitative interviews to get community perspectives on their needs and barrier to treatment access. Cross-verify medical examiner records with the emergency service overdose data to ensure accuracy. For reliability, implement naltrexone distribution protocols across agencies. Align and standardize documentation of distribution inventory. Annual auditing of distribution counts will avoid underreporting. And update any software as needed to be consistent with population density and recalibration. Data collection, this was a quantitative evaluation using descriptive and geospatial data. Data was also statistically analyzed to look at any racial and ethnic demographics and the naltrexone coverage correlations. Implementation was overdose high-risk areas with high clusters of overdose compared against the distribution of the treatment. Improvement for data collection would be to include drug-specific exposure surveillance. Use real-time emergency service overdose dashboards rather than doing a retrospective analysis, and integrate harm reduction reporting sites such as mobile vans and in shelters. Research studies that are carefully planned with cultural responsiveness and integrates measurement, accuracy, and reproducibility will be able to address health disparities in vulnerable communities. Thank you.